I'm going to give it another maybe 20 or 30 seconds and then we'll. Okay. Okay, great. All right, yeah, as Michael said, thank you again for coming out in the cold and maybe melting in slushy snow. Maybe you're all glad to be out of your homes and dorm. For those of you online, we recognize many of you guys are juggling children and maybe fighting for Zoom amid online schooling, so we really appreciate everyone coming. I'm Megan Hutchko. I'm the director of the Center for Global Reproductive Health here at Duke, and I'm really excited to moderate this panel on menstrual health equity, global perspectives, and local innovation. Before we get started, just to let you know, today's session is going to be recorded and then will be posted publicly. So what you say or post in comments can be seen by others. And then we've left time for Q&A, so start thinking of your questions. We welcome questions from the in-person and online audience. I'll remind you again, but in person, you can just raise your hand, and then online participants can put questions into the Q&A tab at any time, and we'll be monitoring that so we get to as many as possible. So today our speakers are going to share their insights from research on stigma and physical and mental health across the lifespan of those who menstruate, and discuss systemic change, grassroots innovations, and advocacy efforts. The session will highlight how global perspectives and local solutions intersect to promote dignity, health, and justice for all who menstruate. And I'm delighted now to introduce today's panelists. And I'm really thrilled that we have these three speakers who provide three different and unique perspectives. I think we'll all learn something today. I'm just going to give their brief intros, but we have their full biographies on the event website. Dr. Hannah Taylor is a senior lecturer in the Thompson Writing Program at Duke, and her research focuses on reproductive justice, feminist methodologies, and digital rhetoric, particularly at the intersections of health, disability studies, and gender. And she's going to talk today about rhetoric and menstruation. And I think this is a topic we don't normally hear in these global health spaces, but I think it's really important to provide some insights about how the way we talk about and describe menstruation reflects social values and beliefs and have myriad ramifications on people's experience towards and of menstruation. And then Dr. Emily Chernak is going to talk. She is a clinical psychologist who has a primary appointment as an assistant professor in the Department of Psychiatry and Behavioral Science, and a secondary appointment as an assistant research professor here at DGHI. She's also an affiliate for the Duke Center for Global Mental Health. And I have known her since she was a PhD student here, and she will be talking some about her work on menstrual health and menstruation among adolescents from her dissertation, which was done in Tanzania, but is going to span to her emerging work on menopause and menstrual health. So I think that's a really unique perspective that is often missing from discussions of menstrual health equity, is what happens at the other end of the reproductive lifespan. And then Ella, who I will credit with maybe putting the idea together for this Think Global. Ella Bassett is a junior undergrad. She's studying biology and global health and pre-med track, and has a goal of becoming an OBGYN. She has been working on many research projects with me, examining implementation strategies for cervical cancer screening and prevention in rural Western Kenya. She is also my TA, and was an SRT student, a student on the SRT program in Kenya last summer. When she was in Kisumu, she and her colleagues connected with a community organization providing reusable menstrual pads, and they're continuing their work this year to develop a sustainable model for menstrual management in the region. And she's going to talk about some of that today. Okay, so we'll start with Dr. Taylor.
Hello, everyone. Thank you all for having me today. As mentioned, my name is Hannah Taylor, and I'm really excited to speak with you all today and give a little bit of insight into how scholars in rhetoric and communication, my field, are thinking about menstruation, and within this, a light pitch for some interdisciplinary research. Specifically, as a rhetorician of health and medicine, I think a lot about the discursive elements of our life, the language we use, the visuals we engage with, how we are taught, popular culture discussions, and more. These linguistic and representational ecologies of information inform and shape not only what we think about health, but how we think about health. And I think this is particularly true in discussions of menstruation. Perhaps one of the most obvious ways that research on language intersects with menstrual equity is through the discussion of stigma. For example, the view of menstruation as a curse, we all may have heard, emerged in Western societies in the 19th century. Before that, menstruation was called a flower, sometimes a sickness or an ill, but almost always a marker of significant social change. In each of these conceptions, menstruation is never just a biological process, but a cultural one that works to mark menstruators as other through both attitudes and language. However, we argue a lot in my field that in stopping at shame, scholars run the risk of missing the rhetorical impact of menstruation and the many ways it impacts the lives of menstruators. Menstruation is more than a social stigma or othering practice, but an embodied material and cultural experience with many meanings. To illustrate this, I will provide two fairly quick examples for you, how menstruation is framed through education and technology. So as part of my upcoming book, which I officially signed my contract last week, so that is new of this. Thanks. I analyzed contemporary menstrual education books targeted at young people aged 8 to 12. You can see some of their covers up on the screen up there. In analyzing these texts, it became increasingly apparent that the educational materials do more than teach individuals about the biological process of menstruation. They define and enforce a normal period, one that is timely, one that is manageable, and one that is ultimately unobtrusive. For example, the books instruct menstruators to shave, to watch out for their cleanliness, to dress and act in certain ways during, before, and after menstruation. Beyond some of these more mundane norming tactics, these sites of education position menstruation as a stop on an inevitable path toward motherhood, as menarche is the first sign of womanhood. That's increased in everyone, or that's mentioned in every one of these books. This slippery slope is encapsulated in the story of Lorraine told in one of the texts, the period book. Lorraine discusses her relationship to menstruation and the relationship she hopes her daughter has with it, saying, "My feeling about having a period was one of shame. That this feeling was transmitted to me by my mother, who made me feel unhappy about this sensitive moment. Everything she said about the experience was negative. She acted as if a girl should practically go into hiding once menstruation began. I told my daughter, 'Sweetheart, this is a celebration of life. To menstruate is a sign that you will be growing into womanhood, and that's a very wonderful thing. God has given you an important gift with menstruation, the ability to give life to another human being.'" This celebration of menstruation is crucial because it marks the transition to womanhood and motherhood within these texts. I'm happy to speak more on this later, but each of the texts I looked at made this very explicit discursive connection. Menstruation equals womanhood, and womanhood equals motherhood. I bring these examples up not because they are particularly novel to many of us in the room, but to demonstrate how these discursive patterns begin early and do not leave menstruators throughout their lives. As another brief example, smart menstrual technologies mimic these kinds of patterns. For example, the texts provide models on how to properly track your period. Each of the menstrual education books I mentioned contains some kind of chart for readers to copy to keep track of their period. One text mentions explicitly that part of managing your period, and huge step to owning it, is charting your menstrual cycle. So the ubiquity of tracking advice suggests to young audiences of the books that tracking is integral to being a menstruator, and that in some ways you have a responsibility to track and closely monitor your cycles. What is more interesting, perhaps, than the suggestion to track is how the text frame the purpose of tracking, to better know your body. This line of logic continued in many of the discourses I saw around a new group of menstrual technologies that use specifically AI to diagnose from biomarkers found in menstrual blood, such as the M-cup, which you can see up on the screen here. After asserting that menstrual health is overdue for an upgrade, the website for the M-cup says, "That's why we are developing the next generation of consumer health tools to manage your menstrual health on your terms. Not only do we want to provide a better period product, we want to give everyone the power to change the quality of life by inherently understanding their health through technology and specialist knowledge." This sort of discussion of empowerment through self-knowledge is likely familiar to anyone who looks at these sort of menstrual tracking apps, and also rampant throughout fem health technologies. Throughout each of the menstrual management technologies I study, the messaging is consistent. More knowledge will allow menstruators to better understand their cycle, and through understanding, improve their health. Empowerment is a slippery rhetorical concept, though, because the assertion of empowerment and improvement through this tracking denies a common reality. We as people often don't have control over our bodies, regardless of how much knowledge we have of them. And this is particularly true in matters of reproduction and health. What then is being communicated to menstruators when the expectation is that tracking equals more knowledge, and through that knowledge and empowerment, we somehow have control? So that was a lot by way of introducing some types of insight that can come from looking more closely at how we, both as a culture and individuals, discuss menstruation. I argue that because menstruation is a multifaceted experience, it is within our collective best interest to approach it from as many disciplines as possible. Language shapes experience, attitudes, beliefs, and practices. And as we discuss menstruation more, we can also think about how to discuss it better. So thank you. I look forward to discussing more with you later.
That was really great, and I already feel like that it just leads right into your discussion, especially if you're working in Tanzania.
Yeah, that was so
Great. Yeah.
interesting. So the term menstrual poverty has been used to describe conditions and situations where menstruation is stigmatized and girls and other people who menstruate don't have the resources they need or the education or the social support to manage their menstruation with dignity and with confidence. So for example, in a lot of settings, girls don't have access to clean water, pain management strategies, absorbent materials, and clean, safe, and private bathrooms to manage menstruation. Discussing menstruation can be forbidden or taboo. And in certain settings, girls are also restricted from certain activities like praying, entering a church or a temple or a mosque, serving food, or doing chores during menstruation, which can be, again, highly stigmatizing and make girls feel really isolated and lonely and embarrassed. So I was very interested in looking at the mental health impacts of menstrual poverty, and that actually led me here back in the day, where I completed my dissertation as a Duke Global Health Institute doctoral scholar. And so my work focused on how menstrual stressors and puberty stressors impacted mental health and reproductive health among adolescent girls in Moshi, Tanzania. So that's the first thing I'll be talking about today. So all of my work is situated around this biopsychosocial model, wherein the way that stressors have impacts on health outcomes like reproductive tract infections, I'll be talking about, is through a dual biological and behavioral route. So chronic stress can lead to a neuroendocrine stress response with immunological impacts, and that can increase risk for something like a reproductive tract infection. And also mental health impacts can change behaviors. And all of this is occurring in a setting where there's a lack of resources, such as, unclean water or not having clean pads, and that itself can raise the risk for infection. So all of these things are interacting together. And so to look at this, I have two separate studies. The first was a qualitative interview study with 10 girls and 10 local adult experts who work with girls, like teachers, parents, and pharmacists. And then we did a quantitative cross-sectional survey study with 700 adolescent girls who were in school. About 581 of those girls had started menstruating and are included in this analysis. We worked with local partners, including KCMC and Femme International, which was a local menstrual health education NGO. They were essential to this project, and they're my wonderful research staff. And so in terms of findings, so first with the survey findings, we found that 42% of girls did not know what menstruation was before the first time they had a menstrual period. The interviews really confirm that this is a terrifying experience. If you don't know what's happening and you just start bleeding and you can't tell anybody, it's a really scary thing. 14 or 15% had reported reaching sexual debut, so having sex for the first time. And among them, 42% had sex for access to menstrual supplies, which is obviously a concerning consideration. A large majority, 76%, had engaged in at least one non-recommended menstrual practice, whether it's using a material for more than 8 hours or wearing a product that's still damp after washing it or a product that someone had already used. And so we asked girls what their stressors were that they were facing during menstruation and puberty. The number one stressor was cramps, reported by 81% of girls, then worrying about leaks and odor, difficulties moving around, having unwanted sexual feelings or receiving attention from others, and acne is a universal experience for teenagers. Then we have the least common stressors, but even the least common stressor of being teased is still reported by 1 in 4 girls. We all know that being teased as a teenager can be just devastating emotionally. And so we asked girls what symptoms they had of a reproductive tract infection ever, in their lives. And over half reported having at least one symptom. But let's say, even if we take away symptoms that might be like a misinterpretation, normal vaginal discharge, especially during puberty, still 20% had pain or burning during urination, 14% had sores, blisters, or ulcers in the genital area. And these are, kind of unambiguously concerning symptoms. And so what we looked at first was the relationship between menstruation and puberty stressors, depression and anxiety, and the risk or the odds of having an RTI symptom. And so I did structural equation modeling. We controlled for age and school. And what we found that is in each case, the different types of stressors, so puberty stress, menstrual symptoms, and menstrual deficits were associated with both depression and anxiety and the likelihood of having an RTI. So on the left, you can see as each of these factors increases, the predictive probability of having an RTI goes up, and that's controlling for age in school, and that the relationship from stressors to having an RTI was partially explained by an indirect relationship with depression. So it's going from stress to depression to having an RTI symptom. We also looked at menstrual pain because this was such a major disruptor to girls' lives. So we looked in the qualitative interviews, and one girl says, to start with the bad things, about puberty, I normally go through severe abdominal cramps, I get sick, and sometimes I don't go to school and I have to stay at home until I get well. Much blood gets out, it causes me a lot of discomfort, and it's something that really annoys me. And this is very common. Girls were having severe pain, vomiting, unable to work and go to school. But unfortunately, the first line treatments were often not available or provided. Part of that was because myths about medications, and including like over-the-counter painkillers being very harmful to the body and to fertility, and also they cost a lot of money. And you need to get permission usually from like a parent, a pharmacist, a medical provider who sometimes don't think girls should be taking medications. So one girl says, the teacher answered that medicine is not good to the body because it becomes poison, and the abdominal cramps that they do get do not require treatment with medicine. So a lot of girls were kind of just dealing with very severe menstrual pain. So the last thing we looked at was menstrual stigma across important social contexts. So in this case, we looked at religion and school because both of those are very impactful for girls. And we found that both Christian girls and Muslim girls who reported having menstrual restrictions. So 52% among girls who are Christian, 76% among girls who are Muslim, so slightly different by religion. And we also saw that menstrual stigma differed by both religion and school. So these two graphs, the top one is concern about public attitudes, kind of like an external stigma. The bottom is negative self-image, that's like an internalized stigma. And the different sections are each different schools. So we're looking across school. And then in red are girls who are Christian, in blue are girls who are Muslim. So you can see that stigma in general was higher among girls who are Muslim than girls who are Christian, and differed across school as well. But in the interviews, girls talked about how, these religious restrictions made them feel more stigmatized because it kind of outs them as menstruating and is embarrassing and isolating and lonely. But this could really be mitigated by having supportive parents, supportive fathers, and a religious community that talked about menstruation or was supportive and provided education. So there's a lot of opportunity for change there. So next, I'm going to talk about what I'm looking at recently, which is this kind of other end of the endocrinological spectrum, which is menopause, which yes, menstruation does cease during this time, but the transition involves a lot of confusing symptoms of vaginal bleeding and menstruation, and it can be still an understudied and stigmatized topic in women's health and women's transitions that I'm really interested in. So, for example, we just finished a study looking at menopause in university workplaces. So this wasn't done at Duke, but it's places like Duke and relevant to all of us. And among 253 faculty and staff who are aged 40 to 55 years of age, we found pretty much everyone in perimenopause or postmenopause reported having potential menopause symptoms at work that were disruptive to their workplace productivity. The top 5 symptoms were physical and mental exhaustion, being tired due to poor sleep the night before, anxiety, irritability, and hot flashes. So it's not just what we think of as the like classic vasomotor symptoms of like hot flashes alone. And we also saw that most symptoms were associated with having worse productivity disruptions, but the strongest effects were due to poor sleep, being tired, and physical and mental exhaustion. And interestingly, having joint pain was the most strongly associated with having worse occupational quality of life. And having poor sleep can also increase pain. So kind of interesting what's going on here with sleep, pain, mood, and the ability to really thrive in the workplace. And the participants had great suggestions for how to improve workplace, not just for women in menopause or women for aging, but like all human beings who have bodies and want to be comfortable. So it's like, if we can use this as an excuse to get these things done, that's great, but I think it serves everybody. So being able to control your own space, your schedule, your temperature, and having that flexibility, and not just for things like hot flashes, but also things like migraines, back pain, etc. I think could be really helpful for everybody. And then lastly, we're just launching a study. Megan is involved with this one too. So we just got funded for this and are starting it now to look at the overlap between menopause and mental health here at Duke Health, looking at the medical record system. And this is all in preparation to be able to launch a study looking at mental health, mood, and menopause in the American South, and especially thinking about different like rural populations as well. But that's just his first step, and really interested in bringing this globally as well. So if anyone's interested, please reach out. But the conclusion for all of this is that women's health transitions are still stigmatized and under-researched, and that stress and stigma and the lack of resources can impact women's health transitions in mental health, their school and work participation, and their reproductive and sexual health. So there's still a need for structural interventions, social interventions, biobehavioral, which is what I'm focused on, to improve women's and girls' experiences all through from menarche through menopause and beyond that as well. So please reach out if you have any questions.
I think I'm definitely going to build off the findings that you mentioned, a lot of the literature that exists in Tanzania on need and accessibility. And I especially loved your focus on moving beyond a perspective of just like material need and physical pads or products, and more of that biosocial, more socio-ecologic approach that looks structurally at what reinforces period poverty. So I am going to talk about a local intervention that I began in Kisumu, Kenya as part of the DGHI Student Research Training Program last summer with two of my fellow students, Sierra Remington and Hope Tuong. So today I'm speaking on behalf of our team of three, but we came to create this community-based menstrual pad intervention in Kisumu, Kenya from our project with Dr. Ichko's cervical cancer screening and prevention research in the same town. So the Duke Center for Global Reproductive Health has offices in Kisumu that we would work in. And this was an implementation science project. So our job was to evaluate and monitor the rollout of an intervention designed to promote screening uptake for women testing for HPV and screening to detect cervical cancer. So we were in the office and out in the field in Kisumu, Kenya, and you'll see on the map it's in Western Kenya, right on Lake Victoria. And that's a picture of our team of three arriving in Kisumu last summer. And while we were there in connecting with past SRT students who had done the same work in the area, we met the people who would become our community partners. This is Rosemary Ojada. She's worked in many different administrative roles for NGOs, but now she runs her own nonprofit called the Garden of Hope, just a few blocks from where our students would be staying. And so after meeting Rosemary, we became really enthralled by the breadth of the work she does in the community. She's incredibly well connected and has a real global health mindset, and is so in tune to what we would consider the heart of global health work. So this is her in her sewing workshop that she runs. This is out of a church in the Milimani area of Kisumu, where she employs around 5 to 10 staff every day. from the community, most of them young women who are working there most days to pay for either their secondary school fees or paying for college tuition or supporting their families. And with household necessities, they take on shifts at this workshop. They make handmade blankets, crafts, and they sell them at local markets. And so this sewing workshop was our first introduction to the work that she does in the community, which is has an incredibly large scope. So through interacting with Rosemary and her sewing workshop staff, we began to really understand menstrual health management, or MHM, and the need for period product access in Kisumu. In talking with several of the young women who worked in sewing jobs, and to Rosemary herself, who has a teenage daughter, and with her friends, we began to really understand anecdotally what the need was. And so what we began to first understand was that menstrual products are, like any other household item, a budgetary issue. They're often deprioritized. They're not top of the list on things to purchase every week. And they're often entirely neglected. So menstrual health is foremost an economic issue. It's common for many girls, especially who are in school, to manage their bleeding with unsafe alternatives that are known to lead to RTIs. So rags, there are rough grocery bags that we would encounter on the streets of Kisumu that are often used as a default for managing bleeding. Leaves and cow dung are some of the alternatives that some of these have reported using when they can access for sanitary pads. And another major barrier to menstrual dignity in the area was just an anticipated stigma. So especially for girls in secondary school, fearing that your teacher wouldn't understand, would not let you go outside or go to a washroom. Especially when it came to male teachers and male peers, there was a real anticipated stigma and fear of being discovered that governed a lot of these students and girls' entire lives. So after learning more about this need, we decided to look into some of the literature on period poverty and stigma in the Kenyan context, which is scarce. But there were two studies that we've leaned on, and they are also very implementation science adjacent. So they're assessing the feasibility and the acceptability of pads and menstrual cups in settings like this in Western Kenya. And some of the main takeaways we found were, again, like Dr. Chernak mentioned, that simply access to physical pads is not sufficient. Period poverty encompasses the structural and sociocultural stigma that governs the lives of people who menstruate. It's not just about putting pads in the hands of these people, but giving them the tools to understand how to manage their periods, to treat them as, moral agents and not just beneficiaries of pad distribution, but someone who feels confident in that they can control and manage their periods. And a real limitation we're discovering is that there really is a dearth of evidence in this particular area in Kenya specifically. So it's hard to understand the whole landscape of need other than anecdotally what we've heard from our visits and talks. Another parallel with what Dr. Chernak mentioned is the practice of transactional sex for pads. Period poverty is, of course, an economic issue, whether it's sex for money to pay for other household items, to obtain pads directly. Obtaining menstrual pads from a sexual partner was reported to be quite common in Western Kenya. This is a study that found that 2/3 of respondents said that they sourced their menstrual pads or whatever they use to manage their periods from a sexual partner. And a lot of times it is transactional sex, but there is limited data on the prevalence of this, what puts people more at risk of this practice. And of course, we want to be cautious in interpreting the data because oftentimes, as in this Phillips et al. Study, girls will report that other girls that they knew engaged in this practice, but not they themselves. So it's hard to gauge empirically. But this is just a picture Hope, Sierra, and I took on our walks home from the office. If you can see on the right-hand side, this was just a mural commissioned, warning against the dangers of transactional sex for free rides. So in context of the broader sexual reproductive health landscape, we wanted to situate what our project would be, and we centered it on the Lancet Commission's sexual and reproductive health and rights definition, which is a scoping definition put out in 2018 that covers SRHR, as it's called, more holistically, and it's called an integrated definition because it contends that in order to have good sexual and reproductive health outcomes, we also need to have control over our own bodies, aka sexual and reproductive rights. And so we wanted to situate our project within a rights-based framework and really understand and think about menstrual health and access to pads, access to quality menstrual health education as a human right. And one critique I would have, if you want to look into the Lancet Commission's definition of SRHR, is that their intervention packages, their crucial interventions points that they recommend do neglect menstrual health. So I don't think they've adequately carved out enough space, in my opinion, for menstrual health. This is another publication that we relied on in thinking about menstrual health and dignity as a human rights issue. And these were 4 action items that we were looking at in designing our intervention in Kisumu. And again, one that we wanted to center was expanding beyond a sole focus on product access. There are things to consider like water and sanitation hygiene facilities or wash facilities that impede access to safe spaces to change a pad or wash a reusable pad or dry it. And so these are all things we wanted to keep. And again, this is a figure that I love that details menstrual health as not an individual issue, but as a public health issue. And so I think we can often be socialized. And I know Dr. Taylor is an expert on this and how we think about menstruation as an issue of the individual and how it's become so privatized in our lives. And so I think thinking of it as a public health issue is really. So onto the actual intervention and what our partners have been doing on the ground in Kenya. We have, in partnership with Rosemary and the Garden of Hope nonprofit, have started implementing menstrual health education talks. And so this is a picture of our latest one last Sunday, in which reusable pads made by the sewing workshop we mentioned are distributed alongside brochures on menstrual health and period hygiene basics that we designed, along with sort of a stigma responsive talk in which girls talk to each other, and it is facilitated by a physician in the community. So here are some pictures of the sewing workshop where the pads are made each week for the health talks, which happen around once a month, depending on school schedules. But here is a picture of inside of the workshop where, again, there's 5 to 10 busy people on sewing machines. This is a recent picture of the Kenya Bureau of Standards officer inspecting the workshop for their KBS approval, and a pack of 6 reusable pads. And so given enough resources, our goal is always to provide each person with that pack of 6 pads. And so I want to I'll speak on behalf of Sierra Hope and I in that working in this context with Dr. Ichko in a cervical cancer screening and prevention research was really good preparation for how to conduct our own intervention and see it through and start engaging with a lot of these really hard practical questions. So we've been learning a lot about implementation science, which is studying how to best deliver an intervention, feasibility, accessibility, how is our time with the young women and girls, how are our pads best delivered and most effectively distributed? So these are some of the questions we're contending with. And one that's on the forefront of our minds right now is using qualitative methods to understand implementation. It's important for us to garner feedback on the pads and how they're being received, used, feedback on the design, comfort, effectiveness. And so that leads me into some of the implementation tools that we'll be developing this semester to hopefully ease some of the practical and administrative challenges that Rosemary and her team at the Garden Hope are facing on the ground. So versus an attendance tracker, we've expanded from about 20 to now over 50 people at every health talk. So we want to make sure we're keeping track of who's attending in the community. We can get demographic information on where they go to school, what age they are, if they have siblings that would benefit. Also sewing logs. Another goal of our project, and one that we really take pride in, is it's integrated with the sewing workshop and supports the women who make these pads. And so we want to make sure their time is respected and that their wages are fair and compensate and balance their existing work with the workshop that also produces revenue. And again, a feedback survey is what we're really excited about rolling out. If at first informally, we want to just get some programmatic data on the pad design, on the brochure design, and our health talk format, and we could improve it. So again, this is our cervical cancer screening and prevention team who really encouraged us to pursue this. You'll see Javan on the far left, who was really critical in talking to our team of 3 about the urgency of period poverty in Kenya and encouraging us to pursue this independently. So these are just some of the standout lessons in implementation that I took from our time on cervical cancer screening and prevention, and have hopefully adapted well to our PAD project. But one thing I want to highlight is just building on existing community infrastructure. We came in and identified Rosemary as an incredible partner and ally, but she had incredible resources, connections, and had already had this idea and a bare bones menstrual health talk in practice. And so we wanted to be of use to her in any way that we could. And lastly, this is a quote that Sarah Hope and I love, and that we hope to be guided by this year as we work on expanding the project. We want everything we do to be guided by the lived experiences of the people who attend the health talks. We just recently received a few videos of some girls sharing their testimonies, explaining to us how they felt about the pads. So our next step is to get them translated from Swahili and Luo, and to understand how we can best improve the intervention for them. But they're always the center of our steps. Just some thank yous, and there you'll see Abby, who's Rosemary Dodd's daughter, who is a key partner in this and an incredible seamstress.
Thank you. That's okay. So now it's time for the Q&A. I don't know if anyone has any questions, or I can start with one. Is there any in the chat?
We do have a question from online, and it's on the topic of menopause and perimenopause. And I think the root question is, like, how are you able to get pregnant? Like, what's the time frame about, like, possibly getting pregnant related to menopause and perimenopause? And then maybe more secondarily, like, how does that look with legislation related to having children?
Well, you can get pregnant until menopause
Okay.
as the gynecologist. So I'll say that. I'm not sure I understand the second part of the question.
This person says, I think I'm entering menopause. However, senators are considering my ability to have a child. I've heard and read that you have a year after the onset of menopause.
I think that menopause is defined as not having had a period for a year. And so after that, that you can no longer consider no longer. Okay. I want to ask about the menopause question, maybe to both Dr. Taylor and Dr. Chernak. I'm so struck by the rhetoric that you described, and I think about idea, like the connection with motherhood and how at the menopausal transition, that's the opposite, and maybe is what Lauren was discussing. It's like no longer have that opportunity, and so there could be some devaluing of that. And we didn't really talk about as much about sexuality, but the other piece of that, but also the aspects of hormonal fluctuations and mental health and what we see in rhetoric in the public discourse about being crazy because she's menstruating or crazy because she's not menstruating. And, you know, as you are observing one of these symptoms that people are having at work due to aging and menopause, the first one that pops up is irritability. And I wonder about opportunities to take control of the rhetoric. So it's not, we're not seeing that, and we probably do already see it in the menopausal transition, but not putting a judgment on some of the symptoms that you're finding. So I wonder if you thought about that or you have thoughts about.
Yeah, we've thought about it a lot, especially for the study on menopause in the workplace, because like we're not trying to say that women are less productive during this time. We're trying to say that we need to focus on these barriers that can be really impactful in preventing women from achieving their full potential, especially in university settings where it's critical for education and healthcare and research. But I do, and I think like, if we measured aging men of the same age, would we also see irritability related to, for example, untreated sleep apnea? Like there's different things that can cause these symptoms related to aging. So I think it's really hard to understand what's going on in a way that's not inadvertently contributing to stereotypes that aren't necessarily true. And that's why one thing was we really focused on these solutions that are really relevant to everybody, not just women in menopause, not just people who are aging, but I think everyone, whether you have migraines or chronic pain or, panic or anxiety or just need a moment in a private dark space without fluorescent lighting, like all of these things can be helpful to everyone. And just in general, a little side note that I talk about menopause is like, we have so little research on it in part because humans are one of the very few animals that go through a menopause and then live after it. And so there's not a lot of animal models for this. But one of the animals that does go through menopause is orca whales. And they've surmised that the reason that this may have evolved is that grandmothers are critical to the society of orca whales. They're the leaders of the orca pods. And so I just think like if we thought about this differently, like menopause is this strength and it like allows women to thrive like longer and be part of society. And we may have evolved this as a really big strength of ours. I think we could look at it in a different way.
Yeah, there's so much there. Yeah, and a lot of the research, it becomes, when you're looking at language closely, it becomes pretty clear that we at least socially frame menstruation as a stop on the way to pregnancy, and like basically anything that happens as part of that experience is preparation for pregnancy, including in these texts things like pain. They're like, people directly say like this is practice for when you're in labor, things like that, to like an 8 to 10-year-old girl, like usually the audience for these. Which, as we can imagine, leaves out a whole host of experiences. People who don't want to get pregnant, people who can't get pregnant, people who are like, post-pregnancy and still menstruating. And regardless of if you want to be pregnant or not, you will likely have more menstrual cycles than pregnancies in your life. That just is sort of, as I understand it, I'm not a medical doctor, but it does seem that happens. So yeah, the sort of way, and that happens in education. It also happens in the sort of like health and wellness industry that has emerged. And this sort of like gap of we don't talk about women's health enough. A lot of those discourses are also like, how can you optimize your cycle for the pregnancy, like for the purpose of pregnancy is sort of the like caveat, the unsaid thing that happens there a lot. Cycle syncing, those kind of discourses that we're seeing emerge. And so I think you you really don't see menopause talked a lot about until recently. And in this sort of like tracking I do of this, like the last 3 to 5 years, there's like menopause influencers that come out. I don't know if you've like seen these people who generally are not like medical doctors, but are like writing about menopause publicly, selling supplements, creating apps to sort of like track your experience around menopause. So I'm really interested in a lot of those discourses. They do try to reframe the experience as sort of an empowering one, but that like always sort of leans too positive and like negates the reality of the physical experience, which can be unpleasant. And so I think we sort of don't do a good job of residing in that gray space of understanding that like this is an important thing to talk about and it still might be unpleasant, and rather than like stigmatizing those unpleasant things like irritability or emotionality, like that's just a reality of the experience. And so how can we like structure our world better around those experiences as opposed to like just talking about them poorly, which does tend to happen. Ella and I first connected over a project on PMDD research. And so I'm currently doing a research project where we're interviewing a lot of people who have been diagnosed with PMDD, and they reflect a sort of similar sentiment, premenstrual dysphoric disorder, which is sort of like a strong diagnosis of a lot of the PMS symptoms that people make fun of, but they struggle with that reality too. It's like something that's coming up over and over again in the data is that they're like, my experiences are real, but I'm taught that they're kind of a bad thing, but they're very much in my body and I'm having them happen. And even, you know, all types of people are like speaking down on that too. So I think there's like, we don't know how to acknowledge that that's a real thing that people are experiencing. And as opposed to like stigmatizing it, we could, you know, adapt our world better to fit that kind of experience.
I think it's interesting, some of these models of, you mentioned what's normal, and there are, you know, we always try to teach you what is normal and, you know, what is you should seek help for, and I think a lot of that is maybe missing in what you had said in Tanzania and in Kenya, and it is a challenge that we have as clinicians sometimes, is that there are now very safe and, you know, health boosting options that mean people don't have to menstruate ever, and, you know, and then they can still get pregnant. So they could put a hormonal IUD in, reduce the risk of cancer, not have to have a period, not have to have these premenstrual symptoms for most people. And there's this very strong feeling in many communities that having a period is normal. And so it's tricky, I think, in that adolescent period to teach young kids how to anticipate something, and it's normal for this to be happening, so it's not scary. And then that's so ingrained that they don't want to get, you know, the treatment that could mean they don't have to have it until they're ready to get pregnant. And so what would be some strategies you could see about changing the rhetoric around that?
That's a great question, because I do think we at least are taught like there's some essential element to menstruation as part of womanhood, at least in how it's like constructed, that like that is like an innate part of being a woman, which I'm using in scare quotes because right, lots of people who aren't women menstruate don't, and lots of women don't menstruate either. So I think I can see that kind of call reflected in this really large anti-birth control sentiment that's coming up. I don't know if you all are seeing that or experiencing that in your world, but I do a lot of like regular polls of like hashtags in like digital spaces, and that's like in the past like 6 months even like expanded very widely, people being very anti-birth control. And I think it's not a coincidence that that's coming up alongside all of these calls to like have more children and sort of this tie to pregnancy as well within our current like reproductive health landscape more broadly. So I think you're right, it's a question of framing at an early age of like, this is like a biological social process you're going to go through because that's like what your body's doing, and sort of how to deal with it in that way. And I'm not exactly sure what the best way to handle that would be, but I do think it sort of starts there. The way that it's framed in these educational spaces is a lot of the times the only education young people are getting about it. They're not being taught in schools puberty as much anymore, specifically in like states where that's like really restricted or monitored. And so it's often a sort of like family discussion, which a lot of people feel uncomfortable about too. And so they're getting these books that they get, and a lot of them are like, this is practice for motherhood. So framing it instead is like, this is something that your body does, and like you can like choose how you exist in the world alongside that. I'm not sure exactly how we would frame that to young people, but I do think that's where it starts. Like that's where the conversation should start about it.
I have a follow-on for Ella with that, unless there's someone in mind.
I have several questions from online. One ties in to what we've just been talking about. So I'm gonna then just go to the second part of their question, but how could shifts in menstruation and menopause rhetoric help reduce some of the negative consequences you've described or strengthen the efforts that are already taking?
That a question for me?
It's addressed to the whole panel. But
I think what I'll talk about is, so my expertise is more about rhetoric, the way that people think about themselves. Like I'm a clinical psychologist, right? So I definitely think the way that people internalize and frame these issues when talking about their own self-worth and their value, and also in thinking about like, for example, like girls who have more catastrophic thoughts about pain and menstrual pain actually have worse menstrual pain. So like the thoughts that we're having about these concepts can really impact their bodies in a real way. So like, for example, in the case of our study where, we found that the menstrual pain treatments, like, ibuprofen and Tylenol were really not well received by the community. So instead that I worked with the NGO and we built in more of like a menstrual pain coping, where it's thinking about the pain differently, learning like deep breathing and other pain management techniques just to meet folks where they are. So I think there's definitely, we can draw from the world of psychology and cognitive behavioral therapies and acceptance-based therapies that focus on changing the way that we think about things to feel differently and actually have different physiological outcomes. But then I would rely on the expert to think about the external rhetoric and how to change that.
I'll say briefly too, just real quick, since I've been talking too much. We talk a lot about in rhetoric these things called like silos of or cycles of silence, where like the research is all like, we don't talk about this, and then like it keeps us from actually talking about it because all we're talking about is how we don't talk about it. And so I think one thing is to just start talking about menopause and letting people get comfortable with the reality and not, that sort of introducing regardless of your gender, you're getting all of this education. We still have sort of like split sex health education. And so it's like, no, you need to learn about all of this because it's a human experience. I think can sort of start that conversation. And aside from just saying like, we don't talk about it, like implementing things like that is a good way to start.
Yeah, I wanted to ask, kind of like when you're talking about things you don't talk about or things like that. You brought up like cycle syncing, but I kind of was just curious, like everyone's thoughts on those kind of like hormonal fluctuations throughout the month related to the menstrual cycle. And like, I personally feel like that was like a positive thing people started talking about, but it kind of seemed like I had never heard it framed as like a pregnancy thing, more of like a how you live throughout the month in a way that like other people might experience like a 24-hour cycle, how like a monthly cycle might be different. So I was just kind of curious, like, how would you all feel like that fits into like the research agenda and how that can be a conversation with women, or do you not feel like that's a space to be in?
Oh, I was just, I've only read about or learned about cyclosyncing in the sense of like athletics is where I feel like a lot of people have focused on that outside of pregnancy and either trying to become pregnant or trying to prevent pregnancy, right? So and the research, as far as I know, hasn't really held up. But I definitely don't think there's enough research outside of premenstrual dysphoric disorder for mental health and thinking about how maybe the different ways you cope or like go about your life and treating yourself more gently at certain times of the month or anything like that. So I feel like there hasn't been a lot of work in that area that we explored.
I'll say quickly, I think it's like a historic practice. Like cycle syncing has been around for a very long time. And it's a very indigenous practice as well. So I think it's also like, who are we getting the knowledge from and who is presenting it to us now is always my question, like the things I kind of think about. And I think often it is presented in the context of like, and to fix the problems you notice, like take this supplement, buy this app to track it. It's like very tied to sort of a capitalistic ideology. And so I don't think the practice, and again, what I have read on it is that it's not always like, we don't have enough research to know like how based in like medical science it is, but that it's not like a bad thing to know more about your body, but for what purpose are people instructing you to know more about your body? And in the vast majority of cycle seeking discourses, it's to buy something or to like, use an app where we don't know where the data is going. Like there's like some murky territory that we get into there. So I think the practice itself, I think, can be very empowering for people when we've seen a lot of people say that, but like who is sort of governing how the practice is used is what I'm interested in.
I had a question for Ella and Dr. Taylor. I mean, your work is on like social reproduction of information around menstruation. And then your project, you're making pamphlets and having these talks on menstruation. Has there been any collaboration between you two on how you put together that information in that like cultural context specifically?
No, but perhaps there should be. Yeah, I found one of the things in attending like one of the health talks in person that I was able to is that you can't help but like contrast with the US context and like what you and your friends talk about when or if you talk about your period. And I think what was surprising to me and maybe a little disheartening was that just like how universal this stigma is. But also there are commonalities in how like a lot of these girls would share with each other and with us the story of getting their first period and all of like the social stigma and like gendered norms that like imbue and like shape that story. So I think there's so much more like that different contexts have in common when it comes to this issue, especially like adolescence. I think it's easy to like paint with the broad stroke and like have this idea in your head that like going to Kasumu and like participating in a menstrual health education event will look a certain way. But it was like strikingly similar to like how I would sit in a circle and like share my story if I were doing it at, like in my hometown. So I think that would be really fruitful. Yeah.
This is a fun fact. Ella was in my 128 as a first year student. So this is so fun.
Yeah, thank you all for the great talk. I have a question for Ella, I guess. So it's really interesting when especially when the other two speakers somehow shows that how actually prioritization became a really important factor or features in what we're discussing about menstrual issues, but then somehow you offered a quite different way, I would say more a community based, and then somehow a little bit giving what you have offered us, it's a kind of public, somehow semi-public affair for this kind of issue. So I guess for me, I would just, I'm more curious about how would family as another, I would say a third party maybe, or are part of the community, how is the role of the family, especially the maternal relatives and maternal, like, intergenerational links, play a role in what you have proposed in the community-based support and organization for better dealing with women's menstrual health?
That's a really good question. I'm sure Dr. Chernak can speak to this in like the Moshi context too. But what I've learned anecdotally from participating in the health talks and talking to girls is that, like Dr. Chernak said in one of her literature points, that a lot of girls don't know what menstruation is or what's happening until they get their first period. And so then that usually like prompts a talk with either like a sister, an aunt, a mother, a female relative. And several have shared their stories and that there's maybe one person in their family that they've trusted to confide in. And that can be a sister or a mom, but that it generally doesn't expand beyond that. And so I think that, yeah, like a family-based intervention would be really like important, I think. And a lot of families do attend health talks together. So there are oftentimes like toddlers running around, mothers with infants who come, and like a lot of mothers will receive pads as well, something they can share. Yeah, I think that also brings up the question of like, how do men and boys take part in this? What is their role? And I don't know if I know the answer other than
The interest in another type of silence.
Yeah, cycle sciences, and other than to somehow make them more intensive, active participants. Do their best to convince them that this is their issue too.
Do we have time for one more? I saw one hand.
Well, that was actually my question is, what recommendations do you have from strategies around male allyship, around menstruation and menstrual health and menopause?
Strategies around male leadership, is that?
No, allyship.
Allyship.
Menstrual health and menopause.
Yeah, I can certainly say so from my study, like even though we asked girls like who would you want to receive information and resources from, the number one source was mothers, but like in these contexts, families are really diverse, caregivers are really diverse. You can never entirely just rely on one person. And prior research does show that when boys are given education on menstruation, there is less teasing in the classroom setting. So I think boys, we talked to community advisory board, they're eager to learn, they would like to know more, certainly. And then in the United States context, a lot of what the women were saying in employment settings is that the impact of managers is really critical, and that they felt so much more comfortable when there were other women of the same age who understood what they were going through. But having a lot of older male managers, it led to a very like awkward context where people couldn't really speak openly. So I think some people really wanted education in the workplace setting, others felt it should be held somewhere else. So I think no matter who you ask, everyone's going to have like a slightly different perspective. But I definitely think providing information could only possibly be helpful for boys and for men and for everybody, and just showing like this is a health thing that impacts all of us, just as we all need education about aging in general, I think as well.
I would also suggest that's where it kind of starts at the family, right? Because the people who are most important to you might have the most impact. So for, within partnerships and for children who have mothers going through menopause or siblings going through menses, I think that's where the allyship can really be started, and then leads to modeling behavior in school. I mean, adolescence is so hard, right? So it's like having that solid foundation to like be a model for not bullying or understanding or just talking about it with friends is so important. Thank you all. I thought this was a really great